Good morning, students. We're going to start on our journey through Chapter 20, Safe Medication Preparation. This chapter will continue through a lot of the semester, probably up till the end, actually. So today we're going to talk about slides 1 through 9 up to slide 10. Once you get to slide 10, you can stop listening, and we will take up later at slide 10 for another lecture. So safe medication preparation is from chapter 20 in your Perry and Potter Clinical Skills and Techniques book. This is different from your pharmacology book. Your pharmacology book is by Vivosky, and this one is by Perry and Potter. Please refer to Vivosky for most of the semester when Ms. Robinson is lecturing. I will be lecturing from the skills book as I am the skills lab instructor. So we're going to begin with the beginning of chapter 20, safe medication preparation. And we're going to go over standards of care, patient-centered care, safe administration, and eventually we'll go over preparation of medication, math and dosage calculation, the nursing process, and we will talk about medication errors and safety. So to begin, go to the first slide. The nurse has full understanding of the administration and related implications. As a nurse and a licensed nurse, you'll be expected to understand the implications of what you're giving and how to administer it safely. We will be using your drug book most of the semester to look up these points, and we will teach you a systematic fashion to use the book so that you'll use it the same way each time and get much faster at it. One of the things that you'll be looking up in that book is the implications. We will talk about that further. Safe administration requires good judgment, critical thinking, and clinical decision making, which is something that will come as we go through the semester. You're not expected to understand the whole administration of medications safely at this point. You'll be using an assessment, which will be gathering the data about the patient and understanding what the medication has to do with the patient's diagnosis. And we will be putting these words, pharmacotherapeutics and pharmacokinetics, into memory, but we won't be using them often. Okay, medications have more than one name. A trade name, Ms. Robinson will talk about this, is always capitalized. It oftentimes has a little trademark circle in the upper right-hand corner. For example, Tylenol, it starts with a capital T, and it is a trademark name for acetaminophen. The generic name is acetaminophen, and the chemical name of Tylenol is something that is very difficult to pronounce. It's just the chemical name. We classify medications by the effect on the body. In other words, an antihypertensive would be for hypertension, okay? And what it may relieve, hypertension, and the desired effect, antihypertensive. That is just an example of a medication classification. Medication forms, we'll talk a lot about the forms of medication and what forms they come in. If you'll please refer to chapter 20, page 503, table 20.1. All the forms of medication are there. We'll talk about these a lot through the semester, but they could be, oral, capsule, topical, injectable. All of those are different forms of medication in different routes. We will study a little bit about how the medications get into the body and then how they get out of the body. As a nurse, especially a first semester LPN student, you need to understand that when we put something into someone's body, of course it has to be absorbed, metabolized, which is broken down, distributed, which means it goes to the target organ, and then excreted. We will talk a little bit in about slides coming up about how these processes happen. You don't have to know the physiology of all of it right yet, but you do need to know the words excretion, which means how the medication leaves the body, okay? And you have to know absorption, that's how it gets into the body in molecular form. You have to know distribution or metabolism, which is how it gets to the tissues and organs that we want it to get to, and then metabolism. It reaches the site and turns into a different active or inactive form, and then excretion. Excretion takes place in several organs in the body. We talk a lot about the liver and the kidneys, but remember that something can be excreted through the lungs, especially if it's inhaled, and perhaps through the bowel into the stool. And so there are more than one form of excretion. Okay, actions, you'll have to know these words. You'll be tested on these terms, and these terms are something that you will see frequently. Therapeutic effects means that the medication has an intended response. Okay, that's the therapeutic effect. If I give someone a blood thinner, the therapeutic response is that their blood is thinned. If I give them a blood thinner and they begin bleeding profusely, that might be a side effect. Okay, so a therapeutic effect is the intended response. An adverse effect, remember this, is unintended and undesirable and unpredictable. So that may be something such as anaphylaxis or a severe allergic reaction. It could be anything that is undesirable and unintended. A side effect is predictable. So think about that. I can tell you that if I give codeine cough syrup, it's predictable you may get stomach upset. So that is a side effect. It's sometimes unavoidable, but in that purpose, let's say codeine cough syrup, it's intended to decrease the cough. So I, as the patient and or nurse and provider, would decide if the side effect is not something acceptable for the end point. In other words, if the cough is suppressed. Okay. So side effects, predictable, unavoidable. That might be nausea from something. Adverse effects, unintended or undesirable, often unpredictable. Okay, those are the words we're going to be using very frequently throughout this semester. In your book, you will see that it uses the words ADE for adverse drug effect. All right, as we continue on here, to the next slide, we can have toxic effects that may happen. Oftentimes that may be from prolonged usage. Our elderly patients sometimes get toxic. If metabolism is impaired, let's say liver disease or kidney disease, these toxic effects may build up and they can lead to unintended horrible consequences. For example, an opiate, which would be something like morphine for a pain relief, could depress the person's respiratory drive and keep them from breathing often enough or deeply enough. Okay, so a toxic effect. Idiosyncratic means we don't know where it comes from and it is a different reaction than normal. For example, we may give Benadryl to help someone with itching or keep them from having watery eyes or itchy eyes, but it may make them hyped up and hyper. Or we might give something to put someone to sleep and help them to rest for anxiety, and it could make them more anxious or jittery. Those are idiosyncratic reactions that we do not want to happen. Okay, allergic reactions, as I said, are unpredictable. Remember and write down the word anaphylaxis. It means angioedema, which means swelling of the cheeks, tongue, throat, whereby we may have an airway issue. Patients with known allergies, especially those that might cause anaphylaxis, should have an allergy information bracelet. Antibiotics are a big culprit of this type of reaction, and we want to make sure that we are telling our caregivers that that is an existing horrible allergy that might cause anaphylaxis. Okay, we're going to talk a lot over the semester about tolerance dependence, interactions, and these words are going to be very interchangeable. So tolerance means something very simple. Over time, over a period of time, higher doses are needed for the therapeutic effect. Okay, as you see here, over time and therapeutic effects, it takes a higher dose. For example, when someone uses a sleeping pill, they start off on a very low dose, and after 10 years or 5 years of taking it, they need a higher dose to be able to fall asleep. That's just an example of tolerance. There can be dependence. This is another word. So dependence can be physical or psychological. Write that down, physical or psychological. Physical means that the person, when they are withdrawn from it, will have physical symptoms, perhaps intense, perhaps shaking, just like withdrawing from something that you are dependent on. Psychologically, when someone becomes dependent, they depend on it for the desired effect that it gives them rather than the intended effect. When the pain is gone and someone is addicted to pain medication, they take the pain medication for the effect that it gives them in a different way psychologically rather than the fact that they are taking it for pain. Interactions, we're going to talk a lot about. I want you to write down agonist and antagonist. An agonist is something that helps or enhances the action of a medicine. We may give something together because they are enhanced by one another. Antagonist means that one may block the other. So we are always thinking about agonists and antagonists. Some of our biggest problems for our elderly are that they suffer from polypharmacy. Write that one down, polypharmacy. Polypharmacy means that they take many medications and there are interactions between them. When you give 20 pills in the morning to a patient, you oftentimes may have polypharmacy happening and you wonder if there's an interaction or an antagonism between several of them, and that is quite possible. So that may alter the way the medication is metabolized in the body. So agonist and antagonist is something that you need to know. That may block the effectiveness or enhance it. Okay? Moving on to response. We see here in this graph the toxic concentration we're trying to avoid, the therapeutic range that we are trying to achieve, whereby we have the amelioration or the discontinuance of the symptom, and then we want there not to be a very low level in the body. So safely therapeutic. The duration, as you can see here, is something I want to talk about as it relates to the words half-life. Half-life. So I want you to write down half-life, and we're going to talk about that as well with Ms. Robinson. Half-life means when the excretion of the medicine lowers the serum level by half. Okay? Excretion of the drug lowers the serum medication concentration by half. How long does it take before half of the medication is out of the body is called the half-life. That is something we will talk about very frequently and that you need to know. You can look it up in your book if you want to give yourself more information about that. So half-life is where we're talking about for duration. How long is the medication in the patient's body? How long can I count on it working and causing the therapeutic level that I was giving it for. Okay, now you may stop here. We will start next week on slide 10, routes of administration. If you are continuing to listen, we're going to talk about routes of administration, and we have several of those. The route that's prescribed is how we administer the medication, and it depends on the medication's properties and the desired effect. So route may have non-parenteral. I want you to write down parenteral and non-parenteral. Check table 20.4, page 506. Things that are non-parenteral are medications that are given that are not injected through the skin. So that could be topical, a cream, something under the tongue, a pill, okay? So without injecting it into the body, it's called non-parenteral, okay? And then parenteral is injected in some way, shape, or form into the patient's body. So if, as a nurse, I feel perhaps like the medication for nausea that I'm giving them by mouth is ineffective because they are vomiting or having emesis, I may ask for a change in route to rectal. Okay, that's just an example of two different routes, per rectum and PO or per os means orally given. Okay, distribution we've talked about a little bit in the last slides, but in this case what we're talking about is an automatic drug dispensing system, or a Pyxis or an Omnicell. Okay, so when we have electronic distribution, oftentimes the pharmacist is checking it as well as the another nurse, and you would get the medication from a electronic machine by giving your ID, and you guys will see this in several different forms through the semester. They're computerized. They allow for scanning of the medication, scanning of the patient, safe storage, and more control and less errors when we're using an automatic dispensing system, such as the Pyxis or the Omnicell. Okay, here's automatic medication dispensing system, just a picture of a Pyxis. This is still oftentimes what the Pyxis looks like in the medroom. They're secure. You have to have a fingerprint and a password so it can be tracked back to when it was given, who gave it, and to what patient it was checked out. It automatically documents the medication being given for you. Moving on, without spending too much time on this, barcodes are extremely important because the scanner will scan the medication. We have less errors that happen from that. And the patient also has a code on their bracelet that you scan to make sure you're giving the right medicine to the right patient. This has taken down errors quite a bit, and it has really improved the ability of us to keep a record of the patient's MAR, medication administration record. So this is an electronic MAR as well. Okay, you will be in your dosage calculation class, math class, learning about systems of measurement, medications, dosages. We use the metric system. Household measurements are sometimes given, such as teaspoon or tablespoon. We usually will put that into mils or grams. And a solution is something where a powder and a solution come together, such as putting water into powder to make amoxicillin. And that's called a solution when we have put solid into a liquid or fluid form. Okay, you're going to hear us talk a lot about patient-centered care. Patient-centered care means individualizing the care to that patient and making sure that it is correct for that patient. It's our responsibility to make sure that we communicate effectively with family and/or caregivers. And teach at the bedside is what we do. We will talk a lot about cultural factors, cognitive factors that might influence how a patient can understand or communicate with you. as it relates to their understanding perhaps of a medication. These are the 9 rights of medication. You'll need to commit these to memory. We'll be asking you to use them as you administer medications in the lab and in clinicals. Every time you give a medication, you need to go through these 9 rights every time. You'll get very quick at it, but they begin with right medication, right dose, right patient, route, and time. Right documentation, reason, response, and right to refuse. So each time we give a medication and we take it out of the drawer, we're making sure it's the right medicine for the right patient, for the right dose, and the right time. That can all be done within seconds. It's very quick. And then documentation comes in real time, meaning as soon as I give it, I document that it's been given in real time, not before. The right reason, is it a hypertensive medicine? Is he hypertensive? If the response would mean I've evaluated the patient, did his blood pressure come down? Right to refuse is always in the forefront of our mind. Patients always have the right to refuse medications. What we always say about that is that you should educate them as to the reason they're taking it and what may happen if they refuse it. And then you would chart it. Okay, right medication, here we go. Is it what's been ordered? Is it confusing? Does it need to be clarified? Clarify, clarify, clarify. If you do not know or cannot read someone's writing, or you feel like it was supposed to be written another way, you need to clarify it. The buck stops with us as we put the medication into the patient's body by injection or by an oral means. It is our responsibility once we have administered it. The pharmacist is not there to protect you. The provider is not there to protect you. So you will need to perform a good assessment before you give medications. And then comparing it several times to make sure that you're giving the right thing with all the 9 rights. But right medication is the first one. Next, we're going to talk in the lab and in lecture about how to take a medication order. They're oftentimes electronic now, and they can be written, verbal, or telephone. Each order has to include several things, and we will have a slide and a lecture about the components of an order. There are 7 components of an order. They must all be present every time for the order to be complete. If they are not complete, you will call to get a clarification from the provider to make sure that you will complete the order. Here are some rules for stat and now orders. A now order has to be given within 90 minutes. A stat means immediately or stopping what you're doing to give it. PRN means as needed. As needed means I have assessed the patient and I feel it is a need, and the patient has given me the reason. Let's give you an example. PRN for nausea and vomiting. The patient has said they are nauseous. They feel like they're going to vomit. I have a PRN order for something for nausea. I have assessed the patient needs it. The patient is asking for it. Then we would give a PRN. Okay. For a PRN order, there always must be a reason. In other words, you can't give a medication for nausea if they're complaining of agitation, even though very frequently nausea medications cause sleepiness. Okay, so we can only give it for the reason it is specified for. Standing order means that you don't have to get an order each time you need to give it. Perhaps, let's say, Tylenol for mild pain, standing order, then we would do an assessment and give it. We wouldn't have to get an order each time. Okay, we're moving on to the right dose, double checking that, oftentimes with a scanner. In the care facilities where we will be in clinicals, most places have scanners now. So we do have that little bit of fail-safe to keep us safe from giving the wrong medication. We will spend some time talking about medications that cannot be crushed. So keep in your mind there are medications that cannot be crushed or split, and That would mean you have made a medication error. If you crush something that is not crushable, that constitutes a med error. The right patient. We saved to you that you will need 2 identifiers. It is very easy for me to tell you that the patient should tell you their name and date of birth. When someone is comatose or very confused or has delirium or dementia, that is not always possible. So making sure that you have other identifiers. It could be a picture that you see in the chart of the patient. It could be a family member who says, this is Jim Jones and this is his date of birth, this is my husband. We always would like the patient to state it for us, but that is not always possible. Okay, right route. We will talk a lot about different routes. In your book again, which is your Perry and Potter book, routes of administration are on table 20.4, page 506, and we have non-parenteral and parenteral, and those have a lot of subheadings underneath them. But if it says injectable, I can't give it by mouth, right? I can't change the route. It is not in my scope to decide a better route, okay? Medication errors involve a lot of wrong routes. If it doesn't say per rectum, we need to make sure that it says that, or we can't, put it in injectably when it is a medication that is oral, okay? Right time. Time is on the MAR and frequency is on an order. So you may have a frequency that says give BID, which is twice per day. That's the order. On the MAR, medication administration record, it will say 08 and 2000. Okay? The MAR will not say give BID because a MAR has to be very accurate. So once we transcribe the order from BID, then it goes into the MAR as 08 and 2000, perhaps 09 and 21, perhaps 10 and 10, whatever the order is. Then we will, it'll be transcribed onto the MAR as times, okay? Deviation from the dosage schedule oftentimes happens. Let's say the patient went to CT scan, they went out for x-ray, they are at dialysis. So there are deviations from the schedule. That needs to be charted why it was or was not given as per order. It is not in your scope to decide, I will give it to him later tonight when it's ordered for AM. Okay, that is not in your scope. You'll need to get an order for that. If you say to the physician, she doesn't like to get up at 0600, the resident has requested that her wake-up time is 9. We need to change the AM meds to 9 and 21 instead of 6 and 6. But that's not in your scope. Okay. Documentation happens in real time, as I said, as I pop the medicine, and then when I give it, I chart that it's given. Always remember that if you chart something, let's say you chart a pain pill, and you go into the room and the patient is nauseated and vomiting and doesn't want the pain pill, you then have popped the pill. You will have to walk through the system of getting the medication wasted, charted why you popped it before you gave it. So I will teach you the correct way, which is when they have taken it, I go to the MAR and say it's administered. That isn't really sometimes what happens. And you will see that in most cases, the nurses will pop the medications and touch the MAR saying it was given and then walk into the room. Then they will have to come back and rechart if that medication is not given. Okay, preparation just involves reading the label. You will do a lot of label reading through this entire semester. You are going to be a nurse. You must read directions. We take orders and we read directions. That's what we do. So when it says 5 milligrams per mil and the dose is 15 milligrams, you need to know that you give 3 mils. So it's very important to read labels to know what it is you're giving in per unit. Okay, you will learn to make calculations, either ratios or dimensional analysis of dosages, so that you can quickly and easily and in a repetitive fashion figure out a dosage of something when you have to convert milligrams to mils. We will practice that in the lab. You have to convert within the system. 1 gram equals 1,000 milligrams. 1,000 milligrams equals how many micrograms? Okay, you have to understand which direction to convert that, usually at a glance. And we will practice that a lot in the lab, and you will practice it in math. So in other words, a gram is equivalent to 1,000 milligrams. And 1,000 milliliters is equivalent to a liter. So equivalence must be known. You will use different formulas, usually ratio and proportion or dimensional analysis, to get to your answer. Pediatric doses we won't talk about a lot in this semester, but we do have a lot of older adults, and the dosages oftentimes are dependent on polypharmacy, their renal or kidney clearance, their liver function, their ability to take nutrition and hydration with the medication. This is very important to understand for our older adults. Evidence-based practice are words that we will use with you frequently, meaning there has been scientific evidence that say that the goal and outcome will be met if we follow specific guidelines. Some of those would be something we will talk about week 1, which is there are abbreviations we do not use. Evidence-based practice says that we cause errors when we use abbreviations. Evidence-based practice also says that if you are giving medicines and mixing them, you should be in a zone where you're not interrupted. There are not people coming up to you during a calculation. It says in here, safety vest. A lot of places will wear a vest, meaning if I have the yellow vest on, don't approach me. I am figuring medications. We need to make sure that our care staff knows that if we do have a signal or a symbol showing that we are doing those calculations or we're in a private med room, we're not to be disturbed when we're in a private area preparing medicines. Evidence-based practice says that that will decrease med errors. The nursing process is something we'll talk about frequently. And we will understand how to assess and interpret our assessment, make a plan, carry out that plan, and evaluate the plan during our daily medication passes. We have to think about the reason we're giving it, why we would not give it, and what may happen if we do or do not give a medication. Assessment is the first step. We assess and gather data. That could be physically, by looking in the chart, by looking at the patient's armband, by checking their allergies, and assessing perhaps their knowledge of the medication. The next thing is planning. I will plan that I have to do an IV medication at 11. I will need to do several things before that, so I plan it into my day. Distractions, as I said, will increase errors, and so will being in a hurry. Implementation means carrying out an action, a nursing action. As I give the medication, I focus on my rights. Before giving medicine, oftentimes you'll have a medicine that has a pre-assessment, meaning hold for heart rate less than 60, hold for blood pressure less than 100. That would mean I need to know what that is, the vital sign is, before I give the medicine. If it says hold for heart rate less than 60, I must assess the heart rate. If it says hold for blood pressure systolic less than 100, I need to assess the systolic blood pressure. So what is the action and what is the purpose? What may happen if I do not do that pre-administration activity? What happens if I do not allow myself an area free of distractions? And what may happen if I do not do clarifications of orders that are confusing, written incorrectly, questionable dosages? So pre-administration means you have a safe area to give the medicine, you have all the information you need, and you have assessed the patient. Reading the label, checking it 3 times, double checking calculations. There are medications that are considered to be high risk, and it is required that you have another nurse do the calculation with you. Now you will find that oftentimes this doesn't happen. It is a Joint Commission Medicare requirement. You will see that nurses do not do it as frequently as they should. But when you have what's called a high-risk medication, you are required to have another nurse look at your calculation. Insulin is one of them. Okay, review the assessments pre-administration and make sure that if you're supposed to assess heart rate, blood pressure, blood sugar, pain level, that you do that prior to administering. We always use good hand hygiene in and out of the room. If I have personally prepared the medicine, then I am responsible for it. In other words, if a nurse comes up to me and says, will you give this shot for me? It is, let's say, morphine 4 milligrams, and here's the order. I will have to say, I can't, I did not prepare it. I'm not 100% sure what's in it. You would always be in the wrong if something happened to the patient and they said, who gave the medicine? And you said, I gave it to so-and-so to give it. And then that person gave it without questioning or knowing what was in there. It would never work for you to either be giving something someone else prepared or give someone else an injection or a medicine that you have prepared. When a nurse gives you a cup of pills and there are 6 pills in it, 1 white, 1 yellow, 1 orange, and 3 capsules, you are not, as a student, to be giving those medications, only those that you prepared yourself. This is extremely important for safety. You are not a licensed nurse when you're a student. You are not licensed to give a medication without the approval of an RN or an LPN, and you will not give medications that you have not prepared. So we will continue to talk about that. Make sure that if it's a liquid, the medication hasn't occluded or obstructed the label, and that I can still read the label and the person's name. Okay, these capsules and tablets should be kept in their wrappers. We don't like to open things until we get to the bedside. If the patient refuses, then it won't be something where you say, oh gosh, I shouldn't have given that one was in the cup and he took it. The Joint Commission says that if you have a syringe and you are carrying it across the unit, perhaps a pain medicine or an antibiotic of any type, you are to label it, meaning John Smith, date of birth such and such, Phenergan 25 milligrams. And then you can carry it across the unit. You will not see this happen very often, but this is the standard for preparing something that you take outside of the med room in an unlabeled syringe. Okay, cups and basins are also to be labeled. That is especially if you are holding it, if the pills have been popped and then the patient goes to x-ray, there needs to be a label put on that cup and what is in the cup. Okay, follow the 9 rights each time. Inform the patient what they're taking. Make sure you take it. You see them take it. We are not allowed to leave a cup of pills on the patient's or resident's table. When we come back 2 hours later, a couple of the pills are gone. We don't know what time they took them. We don't know if they dropped them on their lap, if they're sitting on them, if they went on their breakfast tray back to the kitchen. So you will, as a student, each time make sure you see the patient take them, assess their swallow, and then before and after, make sure that they've taken the medication. Know the response. Again, we'll go back to that hypertension example I gave you. Check their blood pressure again in an hour. Have they had the correct response? And remember, they always have the right to refuse. I will mention now that before you give any medications and any med passes, every single time we check the allergies again. I know it becomes redundant, but you will need to say, I know, through the day, I will be asking you your name and date of birth and allergies every time I give you a medicine. I know it seems silly, but that is the rule for me to keep you safe. So again, please tell me your name and date of birth and state your allergies. And you do it every time, okay? When you document, you have just given the medicine. That should be in real time, meaning immediately. If they refuse it, you need to document why, and if you have or have not notified the healthcare provider. Let's say perhaps the patient has been refusing their medicine every day, and the physician knows that. You may be able to make a note saying refused again today. But if it is something that is brand new and it's going to change the status of the patient, sometime you will need to, within that day, you will need to notify the healthcare provider. He has refused his, let's say, bladder medicine and every single day, and now he's having retention of urine. One part of the nursing process is evaluation. This is after you have already done an intervention. So I would look for therapeutic effects, pain is down, nausea has gone away, patient is restful, less anxious, blood pressure is better, okay? Make sure that you're getting a number for pain, meaning what is your pain level now? A 2 in comparison to a 7 prior to the medication. That's an evaluation of an intervention. If you have given a shot that's a brand new shot, you need to make sure that they're not having a localized reaction to where you gave the medication, especially on the first dose. And then evaluation always means, can you tell me again what that medicine I gave you was for? You're having, oh, it's for my blood clot. Correct. And you'll be taking it every day. So evaluation also means patient is able to verbalize or repeat back to nurse the effect of the medication. Okay, reporting errors. If something is an error, it needs to be reported right away. You would go to your charge nurse, and then perhaps above that, we usually do internal audits, but you never, ever, ever chart that a med error was made and an incident report filed. That is a red flag. You will simply make an internal report, meaning you would go to your charge nurse, a report would be given. What is the reason? The reason was because the patient, let's say, was not identified. Or let's say the nurse read it as AM and it was supposed to be PM and she gave it in the AM. Those things need to be owned, and the reason is because we need to do an analysis of why the mistake was made. Was it unclear? Can something be clearer? Can procedures be changed whereby the nurses make less errors? Okay. Report all errors, including omission, perhaps you forgot, and maybe even a near miss. I had the bag of antibiotics and I spiked the bag and I was ready to plug it in, and I noticed that it was 2 grams instead of 1 gram. That's a near miss. I did not make an error, but we need to remove all of the bags that are labeled 2 grams. That might just be an example. Okay, patient and family teaching is very important. Information is power, so for those patients who have the ability to understand the reasoning, they will be able to repeat back to you. Assess that they might need more teaching. Assess that they might need a family member to come help them to understand. Individualize your approach. So if they speak Spanish only, you may need to have an interpreter. If their wife is their caregiver, they may need to be included. If they have a home health nurse, discharge teaching may need to be done for them.